Herkese günaydın.
Good morning. I'm going to talk about the pharmacodynamic and pharmacokinetic factors in drug use in pediatric patients and the general principles for drug use. Before starting with the presentation, I would like to extend my thanks to the organizing committee who made it possible for us to come together in this environment, Congress Organizing Committee and the President of the Congress. I would like to thank you all for making this possible. More than 100 years ago, the Dr. Abraham Jacobi recognized the importance of and need for age-appropriate pharmacotherapy. He wrote, "Pediatrics does not deal with miniature men and women with reduced doses and the same class of disease in smaller bodies." So, while the drug is being used, the reduced doses of the adult doses should not be used. Today, although we acknowledge all these, we see that the drug research among children, due to the ethic reasons that are available today, is almost impossible sometimes, and at those times, unfortunately, the drugs used by the adults can be used in reduced doses. So is this something right? Why should we not do that? The answer to this question is that when you look at the children physiologically, you see that they're different from adults. Physiologically, they have differences with adults, and those differences make the pharmacokinetic and pharmacodynamic factors in children different. Together with the changing of those factors, pharmacokinetics of the drugs, the plasma levels, their discharge and metabolism also change, and in the same way, the relationship of the drugs with the receptors also show a different pattern. A widespread use of off-label medication in pediatrics as well as in child and adolescent psychiatry characterizes the pharmacoepidemiological situations in Europe. This situation is ethically problematic. Most psychotropic drugs used in children and adolescents have neither been developed nor assessed in these age groups. The drugs which are being used off-label, which actually make up the majority of the drugs, make the patients use the drugs without having so much of an insight about those drugs. As a pharmacologist, before starting with the presentation, I would like to talk about pharmacokinetic and pharmacodynamics. When we talk about the pharmacokinetics, we actually talk about the absorption, distribution, metabolism, and excretion of the drug. That is the travel of the drug or the adventure of the drug within the body. When we talk about pharmacodynamic side, we talk about neurotransmitters, receptors, neurotransmitter transporters, and metabolism. Pharmacokinetics in children is different from that of the adults because they are growing creatures. Why? Pharmacokinetics has 4 principles. We talked about those before. Absorption, distribution, metabolism, and excretion are those 4 components. When we look at absorption, we see that gastric emptying and intestinal motility in children are slower and less. Hydrochloric acid secretion is also less in children. Bile acid secretion is less. Therefore, the absorption of the drugs are affected by this. The distribution of the drugs and different body compositions and changes in diffusion. Diffusion also cause different distribution for those drugs. Since the body fluid is different, the distribution volumes are also different, and at the metabolic level, the liver is smaller and the liver enzyme functions are less because the liver is not developed yet, and in terms of excretion there are differences when compared to adults. Pharmacodynamically speaking, we can say that pharmacokinetically they are really different, which means even if the dose we administered was given in a tapered way, the distribution and the metabolism would still be different. So applying that drug to the child on a one-to-one basis would not be possible. Speaking pharmacodynamically, since the child is a growing up organism, the brain until the age of 20 will be affected by this. Actually, the brain growth finishes at 26 according to some publications. After birth, the first couple of years are the years where migration and neuronal differentiation are completed. Neuronal differentiation and migration, even if they are completed in the first couple of years, they continue for a lifetime. Synaptogenesis, elimination of synapses, signal transduction pathways, neurotransmitter metabolism and activation and the enzymes related to those, and neurotransmitter reuptake transporters density, they also change and develop over life. Brain development is a very important process. The brain development continues until the age of 20, and the gray matter development of the brain starts 1 year earlier in girls and finishes 1 year earlier at girls. And cortical gray matter shows us that frontal or parietal lobe take place on month 11, and occipital lobe development is completed at age 20. What does that matter? Wherever the drug we're administering is affecting on the brain, depending on the continuation of the differentiation process, the effect of the drug shows a difference. And going back to the receptor level, this is the situation of the gray matter, but what about the receptors? Let me give you a couple of examples. Psychotropic drugs have very important targets, and dopaminergic system receptors make up this very important targets. Dopaminergic system in the first years, that is in early childhood, increases in dopaminergic receptors or neurons, and this increase between 2 to 5 decreases swiftly, and in each decade there is a decrease of between 3.2% and 2.5%. So a child of 10 and 5, when you use the same dopaminergic system on those children, you can see that there will be a difference, a significant difference, because of the system that they have. Let's continue with the antipsychotics. Neuromelanins are dopaminergic system related protein, and it is absent at birth, and it starts forming at the age of 3. Neuromelanin formation and pigmentation can be completed only at the age of 20. Neuromelanin pigment, especially it has very important antipsychotics which are used in the treatment of psychosis. Pharmacogenetics and pharmacodynamics, if we consider those two simultaneously, the pharmacokinetic changes in children can be deemed as things which prevent the blood range to be within normal intervals. Children are very sensitive about this. From this perspective, since the pharmacokinetics is not completed, pharmacodynamically speaking, the process will not be efficient enough. Here you see an example showing that it is about quetiapine. Quetiapine and serum concentrations of children are evaluated. In 40.8% of those children, therapeutic resistance, that is it is above. In 4.8% it is below, which means more than 50% of the patients using quetiapine cannot reach the normal therapeutic interval. We can see many publications about that in the literature. Shortly, what I'm trying to emphasize is that pharmacokinetics and pharmacodynamics of children are multifactorial and different. Tapering down the doses used for adults and using those for children would be wrong, because that doesn't mean that they would be curative. Pharmacokinetics in children, I would like to talk about this now. Why do I want to talk about it? Because if the situation is like this, the children require individualized treatment. In literature, we see that this is the recommended pattern, the individualization of the treatment. As we all know, we have three mechanisms for this. One of them is DDM follow-up, the other one is phenotyping, and the other one is genotyping. Let me talk about genotyping shortly and the importance of genotyping. In children, body continues to grow, so pharmacogenetics plays an important role. In pharmacogenetics, there is a process where we'll look at the genetic variations of liver enzymes, and by doing so, slow metabolizers, intermediate metabolizers, and normal enzyme activity, extensive metabolizers, and ultra-rapid metabolizers can be categorized in 4 groups. And when we do that, those enzymes, according to their metabolic rates, can help us reconsider the doses to be given to the patients, and rearrangements can be done accordingly. Let me give you a case example here, the last 2 minutes. Maybe you also know about those cases. This is a breastfeeding mother using codeine, and this is about the morphine intoxication. As you know, codeine is a prodrug, which means it turns into morphine after its involvement in the metabolism. A fast metabolizer, CYP2D6 enzyme is affected from this fast metabolizer. So it is turned into morphine, and the morphine is received by the baby through milk, and the baby is intoxicated by morphine, while glucoreduction enzymes, which make the morphine inactive, are not present in children. Therefore, the morphine cannot be impaired and broken down. Since this is the case, morphine intoxication takes place. The reason why I'm showing you this example is that the enzymes in newborns are absent or not functioning at all sometimes. Therefore, this is a group where we have to use the drugs very carefully. So what do we have to do if this is the situation? The required laboratory methods may not be available to individualize the treatment. I will talk about a community of people. Maybe you know those people. This is a network established in Middle America, a network for TDM. In Austria, Switzerland, and Germany, many networks are linked to this information pool, and while setting up this information pool, they want certain parameters to be observed, and those parameters are things like information on the metabolism on the patient, drug use about the patient, dose of the drug, the starting time for the drug, and TDM laboratory data are also asked for. The purpose here is to come up with a big database. For example, in patients using fluoxetine at the age of 10, is the fluoxetine blood level at that level? When this is the case, the side effects are such and such, and the adverse effects are such and such, because otherwise you cannot do a drug trial in children. So at least to come up with a data pool, this initiative has been designed. In my hospital, I benefit a lot from certain publications, and when you read those, you can see that together with TDM follow-up, antipsychotic and antidepressant drug use in certain dosages and the adverse effects on those dosages can be easily understood. And we as the center want to be a part of this group. We've made our application. We meet all the standards that they are looking for. Thank you very much.